Shoulder Dystocia, GreenTop Guideline number 42, second edition, March 2012. Background. Shoulder dystocia is defined as a vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has delivered and gentle traction has failed. An objective diagnosis of prolongation of head-to-body delivery time of more than 60 seconds has also been proposed. Shoulder dystocia occurs when either the anterior or less commonly the posterior fetal shoulder impacts on the maternal symphysis or sacral promontory respectively. There is a wide variation in the reported incidence of shoulder dystocia, between 0.58% and 0.70%. There can be significant perinatal morbidity and mortality associated with the condition even when it is managed appropriately. Maternal morbidity is increased, particularly the incidence of postpartum hemorrhage, equivalent to 11%, as well as third and fourth degree perineal tears, or 3.8%. Brachial plexus injury, or BPI, is one of the most important fetal complications of shoulder dystocia, complicating 2.3% to 16% of such deliveries. Most cases of brachial plexus injury resolve without permanent disability, with fewer than 10% resulting in permanent neurological dysfunction. In the UK and Ireland, the incidence of brachial plexus injury was 0.43 per 1,000 live births. Where shoulder dystocia occurs, larger infants are more likely to suffer a permanent brachial plexus injury after shoulder dystocia. Not all injuries are due to excess traction by healthcare professionals, and there is a significant body of evidence suggesting that maternal propulsive force may contribute to some of these injuries. Moreover, a substantial minority of brachial plexus injuries are not associated with clinically evident shoulder dystocia, with brachial plexus injuries occurring after uncomplicated cesarean sections. When brachial plexus injury is discussed legally, it is important to determine whether the affected shoulder was anterior or posterior at the time of delivery, because damage to the plexus of the posterior shoulder is considered unlikely to be due to action by the healthcare professional. Prediction. Can shoulder dystocia be predicted? Clinicians should be aware of existing risk factors in laboring women and must always be alert to the possibility of shoulder dystocia. Risk assessments for the prediction of shoulder dystocia are insufficiently predictive to allow prevention of the large majority of cases. A number of antenatal and intrapartum characteristics have been reported to be associated with shoulder dystocia, but statistical modeling has shown that these risk factors have a low positive predictive value both singly and in combination. There is a relationship between fetal size and shoulder dystocia, but it is not a good predictor, partly because fetal size is difficult to determine accurately, but also because the large majority of infants with a birth weight of greater than or equal to 4,500 grams do not develop shoulder dystocia. Equally important, 48% of births complicated by shoulder dystocia occur with infants who weigh less than 4,000 grams. Infants of diabetic mothers have a 2 to 4-fold increased risk of shoulder dystocia compared with infants of the same birth weight born to non-diabetic mothers. Table number 1. Factors associated with shoulder dystocia. Pre-labor. Previous shoulder dystocia. Macrosomia equivalent to greater than 4.5 kilograms. Diabetes mellitus. Maternal body mass index of greater than 30 kg per square meters. And induction of labor. Intrapartum. Prolonged first stage of labor. Secondary arrest. Prolonged second stage of labor. Oxytocin augmentation. And assisted vaginal delivery. Prevention of shoulder dystocia. Management of suspected fetal macrosomia. Does induction of labor prevent shoulder dystocia? Induction of labor does not prevent shoulder dystocia in non-diabetic women with a suspected macrosomic fetus. Induction of labor at term can reduce the incidence of shoulder dystocia in women with gestational diabetes. Should elective cesarean section be recommended for suspected fetal macrosomia to prevent brachial plexus injury? Elective cesarean section should be considered to reduce the potential morbidity for pregnancies complicated by pre-existing or gestational diabetes, regardless of treatment, with an estimated fetal weight of greater than 4.5 kilograms. What are the recommendations for future pregnancy? What is the appropriate mode of delivery for the women with a previous episode of shoulder dystocia? Either cesarean section or vaginal delivery can be appropriate after a previous shoulder dystocia. The decision should be made jointly by the women and her carers. The rate of shoulder dystocia in women who have had a previous shoulder dystocia has been reported to be 10 times higher than the rate in the general population. There is a reported recurrence rate of shoulder dystocia of between 1% and 25%. Cesarean section might have been advocated for pregnancies after severe shoulder dystocia, particularly with a neonatal poor outcome. Factors such as the severity of any previous neonatal or maternal injury, predicted fetal size, and maternal choice should all be considered and discussed with the woman and her family when making plans for the next delivery. Management of shoulder dystocia. Preparation in labor. What measures should be taken when shoulder dystocia is anticipated? All birth attendants should be aware of the methods for diagnosing shoulder dystocia and the techniques required to facilitate delivery. How is shoulder dystocia diagnosed? Birth attendants should routinely look for the signs of shoulder dystocia. Timely management of shoulder dystocia requires prompt recognition. The attendant health carer should routinely observe for difficulty with delivery of the face and chin, the head remaining tightly applied to the vulva or even retracting or turtleneck sign, failure of restitution of the fetal head, and failure of the shoulders to descend. Routine traction in an axial direction can be used to diagnose shoulder dystocia, but any other traction should be avoided. Axial traction is traction in line with the fetal spine, that is, without lateral deviation. Lateral and downward traction and rapidly applied traction are more likely to cause nerve avulsion. Downward traction on the fetal head was strongly associated with obstetric brachial plexus injury. Therefore, downward traction on the fetal head should be avoided in the management of all births. Prophylactic McRoberts positioning before delivery of the fetal head does not prevent shoulder dystocia, therefore it is not recommended. How should shoulder dystocia be managed? Shoulder dystocia should be managed systematically. Immediately after recognition of shoulder dystocia, additional help should be called. The problem should be stated clearly as this is shoulder dystocia to the arriving team. Fundal pressure should not be used. McRoberts maneuver is a simple, rapid, and effective intervention and should be performed first. Suprapubic pressure should be used to improve the effectiveness of the McRoberts maneuver. An episiotomy is not always necessary. There was a very low rate of hypoxic ischemic injury if the head-to-body delivery time was less than 5 minutes. It is important, therefore, to manage the problem as efficiently as possible to avoid hypoxic acidosis and as carefully as possible to avoid unnecessary trauma. Managing shoulder dystocia according to the Royal College of Obstetricians and Gynecologists algorithm has been associated with improved perinatal outcomes. Help should be summoned immediately. In a hospital setting, this should include further midwifery assistance, including the labor ward coordinator or an equivalent experienced midwife, an experienced obstetrician, a neonatal resuscitation team, and an anesthetist. Maternal pushing should be discouraged as this may exacerbate impaction of the shoulders. Fundal pressure should not be used during the management of shoulder dystocia. It is associated with high neonatal complication rate and may result in uterine rupture. McRoberts maneuver is flexion and abduction of the maternal hips, positioning the maternal thighs on her abdomen. It straightens the lumbosacral angle, rotates the maternal pelvis towards the mother's head, and increases the relative anterior-posterior diameter of the pelvis. The McRoberts maneuver is an effective intervention with reported success rates as high as 90%. It has a low rate of complication and is one of the least invasive maneuvers and therefore, if possible, should be employed first. If the anterior shoulder is not released with the McRoberts position and routine axial traction, another maneuver should be attempted. Suprapubic pressure can be employed together with the McRoberts maneuver to improve success rates. Suprapubic pressure reduces the fetal bisacromial diameter and rotates the anterior fetal shoulder into the wider oblique pelvic diameter. Suprapubic pressure should ideally be applied by an assistant from the side of the fetal back in a downward and lateral direction just above the maternal symphysis pubis. An episiotomy will not relieve the bony obstruction of shoulder dystocia but may be required to allow the healthcare professional more space to facilitate internal vaginal maneuvers. The use of an episiotomy does not decrease the risk of brachial plexus injury with shoulder dystocia. What measures should be undertaken if simple techniques fail? Internal maneuvers or all-fours position should be used if the McRoberts maneuver and suprapubic pressure fail. The most spacious part of the pelvis is in the sacral hollow, therefore, vaginal access should be gained posteriorly into the sacral hollow. Delivery can then be facilitated by rotation into an oblique diameter or, when possible, by a full 180-degree rotation of the fetal trunk or by delivery of the posterior arm. Internal rotational maneuvers. Pressure on the posterior aspect of the posterior shoulder has the additional benefit of reducing the shoulder diameter by adducting the shoulders. If pressure on the posterior shoulder is unsuccessful, an attempt should be made to apply pressure on the posterior aspect of the anterior shoulder to adduct and rotate the shoulders into the oblique diameter. Delivering the posterior arm reduces the diameter of the fetal shoulders by the width of the arm. The fetal disc should be grasped and the posterior arm should be gently withdrawn from the vagina in a straight line. Delivery of the posterior arm is associated with humeral fractures with a reported incidence between 2% and 12%. Healthcare professionals should base their decision on their training, clinical experience, and the prevailing circumstances. The individual circumstances should guide the healthcare professional as to whether to try the all-force technique before or after attempting internal rotation and delivery of the posterior arm. For a slim, mobile woman without epidural anesthesia and with a single midwifery attendant, the all-force position is probably more appropriate, and clearly this may be a useful option in a community setting. For a less mobile woman with epidural anesthesia in place, internal maneuvers are more appropriate. Persistent failure of first and second line maneuvers. What measures should be taken if first and second line maneuvers fail? Third line maneuvers should be considered very carefully to avoid unnecessary maternal morbidity and mortality, particularly by inexperienced practitioners. It is difficult to recommend an absolute time limit for the management of shoulder dystocia as there are no conclusive data available, but there appears to be a very low rate of hypoxic ischemic injury up to 5 minutes. Several third-line methods have been described for those cases resistant to all standard measures. These include cleidotomy, a surgical division of the clavicle or bending with the finger, symphysiotomy, dividing the anterior fibers of symphyseal ligament, and the Savanelli maneuver. Vaginal replacement of the head, or the Savanelli maneuver, and then delivery by cesarean section has been described, but success rates vary. The Savanelli maneuver may be most appropriate for rare bilateral shoulder dystocia where both the shoulders impact on the pelvic inlet, anteriorly above the pubic symphysis, and posteriorly on the sacral promontory. What is the optimal management of the woman and baby after shoulder dystocia? Birth attendants should be alert to the possibility of postpartum hemorrhage and severe perineal tears. There is significant maternal morbidity associated with shoulder dystocia, particularly postpartum hemorrhage, of 11% and third and fourth degree perineal tears of 3.8%. There is significant maternal morbidity associated with shoulder dystocia, particularly postpartum hemorrhage, of 11% and third and fourth degree perineal tears of 3.8%. The baby should be examined for injury by a neonatal clinician. Brachial plexus injury is one of the most important complications of shoulder dystocia, complicating 2.3% to 16% of such deliveries. Other reported fetal injuries include fractures of the humerus and clavicle, pneumothoraces, and hypoxic brain damage. An explanation of the delivery should be given to the parents. Risk management. Training. What are the recommendations for training? All maternity staff should participate in shoulder dystocia training at least annually. Annual skill drills, including shoulder dystocia, are recommended jointly by both the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists, and are one of the requirements in the Clinical Negligence Scheme for Trust, or CNST, maternity standards. What is the evidence for the effectiveness of shoulder dystocia training? Practical shoulder dystocia training has been shown to improve knowledge, confidence, and management of simulated shoulder dystocia. What measures can be taken to ensure optimal management of shoulder dystocia? Maneuvers should be demonstrated in direct view as they are complex and difficult to understand by description alone. Higher fidelity training equipment should be used. Training on a high-fidelity mannequin was more successful than training with lower-fidelity ragdoll and pelvis. Documentation. Documentation should be accurate and comprehensive. The use of a structured proforma has been suggested to improve accurate record keeping in the clinical setting, and there is some evidence that they are effective. It is important to record within the birth record the time of delivery of the head and the time of delivery of the body, anterior shoulder at the time of the dystocia, maneuvers performed, their timing and sequence, maternal perineal and vaginal examination, estimated blood loss, staff in attendance and the time they arrived, general condition of the baby or the APGAR score, umbilical cord blood acid-base measurements, and neonatal assessment of the baby. It is particularly important to document the position of the fetal head at delivery, as this facilitates identification of the anterior and posterior shoulder during the delivery.